I am Bernard Herschel. Before my retirement, I was the chief of HIV/AIDS at the Geneva University Hospitals. You may call me an AIDS dinosaur who has followed the HIV epidemic from the very first cases in the early 1980s through the triumph of antiretroviral therapies, a triumph unequaled in the annals of medicine. This triumph has its flip side. Younger colleagues are no longer familiar with the opportunistic diseases and the myriad manifestations, hence the idea of these videos. After a short introduction, they will show a series of images illustrating one or several exemplary cases from my files. Cryptococcus neoformans is a type of yeast. It most commonly causes meningitis. It can involve the lung and the skin and many other organs. The patients are usually deeply immunosuppressed with CD4 counts below 50. The treatment is with liposomal amphotericin B, 3 to 4 milligrams per kilogram once daily, plus flucytosines, 25 milligrams kilogram PO 4 times daily, followed by 800 milligrams fluconazole daily. In the cerebrospinal fluid, after staining with India ink, which is now in reality a synthetic stain, C. neoformans' large capsule is clearly visible. Budding forms are typical. Carbohydrate-specific chemicals color the capsule, as with the PAS stain shown here. On the left, subarachnoid space filled with cryptococci at autopsy. On the right, cerebrospinal fluid. Note the cryptococci and shadowy polymorphonuclear leukocytes indicating meningitis. Cryptococci are occasionally seen in fine needle aspirates of a coin lesion of the lung or bronchoalveolar lavage samples. Cutaneous cryptococcosis with ulcerated or umbilicated lesions. When small, they may suggest molluscum contagiosum. Skin lesions in a case of pediatric cryptococcosis. The patient coughed and was dyspneic. The chest X-ray showed pulmonary infiltrates. The bronchoalveolar lavage, colored with the periodic acid Schiff PAS method, revealed yeasts with large capsules and budding forms. Cryptococci were also seen in the cerebrospinal fluid and in a skin biopsy. Cryptococci, other than Cryptococcus neoformans, can occasionally cause infections in the immunosuppressed. For instance, the cat Cryptococcus gattai, as in this case. On the left, the chest X-ray of a patient with meningitis and respiratory symptoms. On the right, cryptococci in a gram stain of bronchoalveolar lavage. Note the characteristic capsules. While being treated for disseminated tuberculosis, this African HIV-positive man complained of pain in his right knee. The X-ray showed osteolysis. A biopsy revealed Cryptococcus neoformans. Cryptococcal meningitis is unusual among opportunistic infections in AIDS in that it is better to wait a few weeks to start antiretroviral therapy. Deferring ART for 5 weeks after the diagnosis of cryptococcal meningitis was associated with significantly improved survival as compared with initiating ART at 1 to 2 weeks. This is probably due to the immune reconstitution inflammatory syndrome, treated in another video of this series. It is also unusual among acute meningitis in that adjunctive steroids do not improve survival and may indeed be harmful. A trial of dexamethasone in HIV-associated cryptococcal meningitis was stopped for safety reasons. Dexamethasone did not reduce mortality and was associated with more adverse events and disability than was placebo. Here is an example of probable immune reconstitution inflammatory syndrome. This patient developed massive lymphadenopathy in the months after starting highly active antiretroviral therapy. The pathology report after transbronchial biopsy described necrosis and granulomas suggestive of tuberculosis, but the PAS stain showed cryptococci, confirmed by culture. The final patient in this video is a 26-year-old woman from Zambia. She was known to be HIV positive since 2006. In 2007, tuberculosis was treated for 6 months with apparent cure. In early 2009, she visited the ER several times, complaining of abdominal pain. Pancreatitis was suspected. On April 28, 2009, however, the CT showed no evidence for pancreatitis, but thickening of the duodenal wall. At endoscopy, candidiasis was suspected, with inflammation of the duodenum and thickened duodenal folds. 2 views of the duodenum with thickened edematous villosities and whitish discoloration. The duodenal submucosa is infiltrated by inflammatory cells. At higher magnification, microorganisms with a large capsule and budding forms suggestive of Cryptococcus neoformans are seen. Three images of Cryptococcus, PAS carbohydrate, HE, and fungiflora stains. Note budding forms. While in the hospital, the patient developed nausea, headache, and diplopia because of an abducens paralysis, indicative of intracranial hypertension. The results of lumbar puncture showed 3+ yeast, cryptococcal antigen agglutination positive at a titer of 1 to 4,000. The culture yielded Cryptococcus neoformans. She was treated with liposomal amphotericin and high-dose fluconazole, later replaced by voriconazole, with early start of heart and recovered. Thank you for watching, and thanks in advance for your feedback. This video is part of a series on opportunistic diseases in HIV/AIDS. If you are interested, please subscribe or click on the latest upload top left.